Well, hello, my name is Deborah Yates and I'm a respiratory physician, and today I'm going to just talk to you about tuberous sclerosis complex in the lungs. And I apologize for the fact that I can't be with you today. I'm sure the conference will be very good and I'd love to have come, but I'm afraid I've got a clashing engagement. So today I'm going to talk to you about TSC and lung issues. I'm going to cover a couple of issues, in particular pregnancy and childbearing, because that's one of the things that concerns a lot of people. And then a little bit about COVID-19, about treatment. And I think the overall message is that early detection and proper treatment with TSC-related lung disease is actually very good nowadays, and we're very lucky to be in this. So what happens to the lungs in tuberous sclerosis complex? Well, as you know, the lungs are involved in tuberous sclerosis complex, but it's not by any means the main problem with a large number of the different patients. The other manifestations of TSC can be worse. And it's probably only about 30% of cases who develop problems. And if one picks these up early and treats them appropriately, the treatment in TSC is very much better than it used to be. And women are much more affected than men, interestingly. Although you can get some of the lung manifestations in men, it's much more unusual. And then now excellent treatments, which I'm sure that you all know about and which I hope you're all on. So I won't go over the clinical features of tuberous sclerosis complex, but I will just say that the major feature that happens is lymphangioliomyomatosis. And I'm going to talk mainly about that. However, it's also important just to cover some of the lymphatic abnormalities that can occur in the chest, because they also may well have an effect on potential breathlessness and treatment. So lymphangioliomyomatosis is a disease with a very long name, and it is a very rare disease. So a lot of doctors won't know very much about it. They will have to look it up. And I think it's fair enough to say that this usually means that it's not a problem for most people. However, you can end up with a load of different problems which need to be diagnosed, and I'm going to go through how this is done and the sort of treatments that happen. In addition, there's a condition called multifocal micronodular pneumocyte hyperplasia, which again has a long name that essentially doesn't cause any problems and is treated by the sort of treatment that people will be on tuberous sclerosis complex anyway. Pneumothorax can be an issue, and I'll talk about that. And then there are a whole load of non-tuberous sclerosis related lung disorders, primarily asthma, which occur in the general population. There's no increase in the other lung disorders, and the treatment of those is exactly the same as for anybody else. I'm not going into the genetics because this has, I think, been very well covered in another session. Just to point out that there is a type of lymphangioliomyomatosis which is so-called sporadic and isn't an association with tuberous sclerosis complex, but it has many similarities, including TSC mutations. And a lot of the patients who present with this are what we call mosaics. So LAM occurs as part of tuberous sclerosis complex and is the commonest lung disease with tuberous sclerosis. Only 4% of people actually present with any symptoms, whereas about 30 to 40% of patients will have lung cysts. Women patients will have lung cysts on screening. So symptoms are a late presentation, and that's one of the reasons that we recommend that a CT scan is done early in order to ensure that the disease is managed properly before it presents. And interestingly, it probably has a milder progression than women who actually have sporadic lymphangioliomyomatosis, although the data on that is not particularly good. And also this multifocal micronodular pneumocyte hyperplasia is more common in TSC. The other thing that's interesting also is that the abdominal complications differ. Particularly the one that we're really looking at St. Vincent's is actually the abdominal lymphangioliomyomas, which also occur with LAM. So what is LAM? Well, LAM is a disease which affects the lymph, the angio, which is the blood vessels, and lyo, which is the smooth muscle. And essentially, this was a histopathological description of the condition, and it was produced early on in the disease before they really knew about these particular types of LAM cells. And as you know, LAM cells are very specific to lymphangioliomyomatosis, and they show many of the features of a low-grade tumor. So nowadays, they are actually classified as a perivascular epithelial cell type tumor. And this is one of the reasons that they probably respond quite well to the specific mTOR inhibition. And LAM cells are specific, and the best way to find them is on a biopsy. As I said earlier, the majority of the features affect women only. So although LAM has been associated with a couple of case reports only in men, it's really women, and interestingly, really women when they reach the age of puberty. And there is definitely a hormonal component to the presentation and the progression of LAM and its female estrogens. So I'm just going to go through a few slides of the lung anatomy so that you understand the sort of slides that I'm going to show you, because I think it's quite helpful to understand the pathology rather than just sort of accepting all the different treatments. And this is a simplified picture of the lungs. And as you'll know, you have the windpipe that splits into two and goes down into the right and the left lung. And as you go further down the bronchial tree, you get to what we call the gas exchange area. This is a higher view of the gas exchange area. And you can see that it has all these tiny little air sacs, which are called the alveoli. And the reason that there are so many of them is that that increases the surface area so that the oxygen can be transferred over into the lungs and carbon dioxide can be passed out. In addition, note the diaphragm is down there, and there is a space between the lungs and the chest wall in order to allow us to breathe. So that when we breathe, the space gets smaller, and then when we breathe out, the lungs actually collapse a little bit down. And this is normally filled with a very, very small amount of fluid, such that you don't notice it. It's a lubricating fluid, basically. And on a chest X-ray, you can see these features. But the thing that you notice is the fact that the lungs are mainly black. And the reason they're black is because they're mainly air. Although the little alveoli are there, they're not very well seen. And what you see is you see the pulmonary vasculature, in other words, the pulmonary blood vessels that go down. But you don't tend to see most of the rest of the lung. This is the diaphragm. These are the lung markings, which are quite subtle for those of us who be looking at it for a long time. We can see those intimately, but it's not so easy sometimes for others. And then there's the important thing, the heart, which I am not going to talk about today. If you look at the lungs themselves, they're beautiful structures. They're very, very thin, only a few cells thick. And what that is designed for is in order to allow the oxygen to diffuse off beautifully. And you can see it's mainly blood vessels here, with these are actually the red cells, red blood cells that you can see, and the alveolar wall that should be very thin. And this is where gas exchange occurs. So the lung itself in the alveoli looks like a little network, a little sort of very thin mesh. And the reason I mention it is because I'll show you in a slide what it looks like with lymphangioliomyomatosis, where there are changes. If you look at LAM, I've put a picture here of the normal lung and LAM here on the right. You can see again these beautiful little networks all the way. These are the alveoli. This is a cross section of the lung, and this is actually one of the airways, one of the alveolar ducts leading down. And you can see how it comes down from, imagine the tree branching all the way out, and then you get at the end, you get these tiny little air sacs. Well, here you can see the air sacs are much bigger in the LAM patient. And there are all these really sort of large, what we call cysts. And there in the corner of this particular cyst is what we call a LAM cell, which is the smooth muscle tumor type cell. And we think nowadays that these are metastasized from other areas, and therefore in many ways LAM is what we call a disease that has spread from somewhere else. This pathology shows these LAM cells really very well, and essentially what they do is they grow, they secrete all sorts of funny substances, and these cystic cells grow, and it involves the lymphatics, which is probably one of the reasons that you end up with such big cysts. And then you get the proliferation or the growth of these LAM cells, and the LAM cells also spread to the lymph nodes and often in the thoracic duct, which is the way in which the lymph drains out of the lung. And there are special stains that we can do for the LAM cells, and they're specific, particular for the LAM cells. One of them is called HMB45, human melanosome black 45. But interesting, they're also positive for estrogen and progesterone receptors, which, as you know, are the female sex hormones. So I'm not going to go into too many complicated details, but I'm going to show you a few pictures just to give you an idea of what it looks like, because it actually helps you understand why these things happen. So this is a CT scan of one of my patients who has tuberous sclerosis complex and infundibulomatosis. And as you can see, this is the lung here. CT scan shows the lung nicely. And these are the blood vessels, these white things going out here. But you can see it's got little holes. These are the cysts. And sometimes people call it Swiss cheese lung, which I think is not very nice, because Swiss cheeses and lungs are not really equivalent. However, you can see how big the cysts can get. And in particular in this one, this X-ray shows nicely that sometimes the cysts can pop, and then you can get what we call a pneumothorax, or air in the chest. So if you compare the left side with the right side, you can see that the lung markings come all the way down to the bottom on the right, but on the left, there's this black area there, and also at the top, and that represents a pneumothorax, where the air has come out of one of those cysts, and that can have problems in itself. So the reason that we screen for LAM in tuberous sclerosis complex is because if we catch it early, then we can actually help with the treatment, and that will save people a lot of problems. So these are the recommended screening modalities. Again, we tend to just do a high-resolution CT scan because this is the best way of showing these cysts, and we tend to do it when people reach the age of adulthood rather than earlier. We can do it earlier, tend not to do it earlier because of the fact that it does involve a dose of radiation, but you can be reassured that with a modern CT scanner, the dose of radiation now is in the region of what it used to be with a single chest X-ray years ago. So it's not high, and it's not like, for example, having a scan of other parts of the body, because most of the radiation isn't taken up by the lungs, because the lungs are mainly air. So it's not like doing an abdominal scan. So it's actually a lot less worrying than it would be if you were having a higher dose procedure. So we recommend a CT scan. A lot of people can't do lung function tests anyway until they're at the age of 18. A 6-minute walk test is hopefully normally normal in people with early disease. And then, it's quite helpful also to actually get early advice about things like, for example, smoking, vaping, and contraception and pregnancy. Again, I'm happy to see girls who are younger than 18, but because I work in a hospital, on the whole, it's 18 is the cutoff point, and often people don't necessarily really want to sort of come and get all these investigations until they're 18. So, but it's flexible. The other thing that we can do is we can actually use what is sort of in the media termed AI, but we've been calling, sort of computer-assisted diagnosis for many years. And you have quantitative CT programs that are now applied to the CT scan. And these are quite helpful because they will actually add up automatically the amount of cysts volume in the lung and compare it with the normal. You can see in the background how it quantifies the exact amount of the volume of the cysts. And this is very useful because we can actually monitor it to see whether things are getting worse. They don't usually get better. Once you've got the cysts, they usually stay. You can't get rid of them, but it is quite helpful for monitoring treatments, and sometimes also the potential for having other complications by actually monitoring the ratio. We can do that also with lung function, but it looks as though the CT is actually probably better than lung function with doing this. So how do people present with LAM? Well, the commonest presentation is with pneumothorax, as I've said. What happens is a little cyst pops, and then you get air inside the chest cavity. And you can see here, it's like the other X-ray. There it is. There's this black part, which is the air, and there's the rest of the lung. I'll talk a bit more about that in a second, but as you can imagine, the other presentation is people who get breathless when they've got large amounts of cyst, which is taking up the lungs. They can't work properly, and therefore they get breathless. Another presentation is when they cough up either blood or milky fluid. The milky fluid is often the lymph fluid or chyle, or they can present with fluid on the lung, which is actually a complication of having leaked the chyle fluid into the lung. The average age of any symptoms is usually in the range of about 34 odd years. So in the middle of the years of reproduction, sometimes people will present during pregnancy, which is a bit of a problem because you don't want to give nasty drugs or do too many tests when they're actually pregnant. And that's another reason to actually see people earlier on. Or they can present with fluid in the abdomen. And there's quite a variable progression. But on the whole, if you've got fluid in the lung, then something probably does need to be done by it. And the same about it. And the same is true with a pneumothorax, because that can get better on its own, but it does cause problems. And there are some emergencies involved in that. So pneumothorax is quite a common thing, actually, that we see quite a lot in hospitals. Classically, people who present with pneumothorax are young men, actually, not young women. So anybody who presents with pneumothorax, who's a woman, I think very carefully about whether they've got an underlying lung disease like LAM or tuberous sclerosis complex. And it's quite something which people usually notice. I mean, it's not something that you would sort of, have without noticing. Often you get quite sharp pain in the chest, and people can remember exactly when that's happened. For example, bending down to pick up your shoes, people will know the exact time. And when it's a sharp pain, it's described as stabbing, and it's worse with breathing, usually with breathing in or out. And that is and often they'll be very breathless. So really, really breathless, not just, I feel a little bit breathless, often very breathless. But this can be really difficult sometimes in children or young people who don't have full capacity. And therefore, it's good that carers should know about this possibility, because it is a medical emergency. And if it's not treated and you've got a large pneumothorax, it can actually cause you to die. So it's worthwhile. And this is a CT, this is an X-ray of someone who has a really large pneumothorax. And as you can see, the lung has collapsed down. This sort of white opacity here is actually the lung collapsed all the way down. And the problem with this is that if it goes on like that, sometimes it can actually cause so much air coming into your chest that it'll compress the heart so that the heart can't pump out the blood properly. And therefore, if anybody presents with a pneumothorax, they have to go to medical care as soon as possible. And this is the classical scenario that you hear about on airplanes. Oh, there was a person on my airplane, and the doctor came along and they stuck a knife in the chest. And in medical school, we're taught to actually put in a biro, because the biro has a thin, it's a thin tube essentially, and it can be life-saving. So although it sounds pretty awful, it is actually sometimes life-saving and worthwhile, but it looks pretty awful. It's not the sort of thing that you want to happen to anybody, really. So the best thing is to get them to medical care as soon as possible. But I should emphasize, this is really rare. This is not something that you should expect. If you've got a normal CT scan with tuberous sclerosis complex, you're not going to have this happen. So it is actually one of the reasons that medical surveillance is very important. And then if you do have a pneumothorax, the treatment is to put in a chest tube. I know I've been talking about a biro, but ideally what we'd rather have is this done in a hospital. And again, what you do is you put a drain in through the chest. You can see that that's what it looks like there. It's a thin tube, and it goes in through the chest wall. And what it does is it just lets the air out, because in the chest is a closed cavity. So it's not going to, the air isn't going to disseminate quickly. Obviously, if there's a hole in the lung and the air's going in faster than coming out, it's going to build up there. So normally we put a drain in. If it's in a hospital, it'll be done under local anesthetic and it won't be painful. But the chest is actually an area that is quite painful and quite difficult to get into intentionally, so that it's not damaged by mistake. But it is a significant procedure, and therefore much better avoided. And the treatment of this sort of thing in the long run is actually a surgical procedure, a pleurodesis. You can put some sclerosing agents in through the chest drain itself, but that's not very effective. And as you can see, if you look at this is a picture taken from inside the chest using what we call a video-assisted procedure. So what they do is the surgeons will put in a sort of camera on the end of a tube, and then they can see where the little cysts are. And you can see that one's really quite obvious, and it has the arrow sign. And then with their this is the remote, so there's a little hole in the chest, and then they put in their instruments through this hole, and they do it remotely, so that they actually basically tie off the cyst. And then what they do is they put in something to stick the edge of the lung up against the chest wall, so that the pneumothorax doesn't happen again. And that's something which is recommended in lymphangiomyomatosis after first pneumothorax, okay? If you've had a pneumothorax for other reasons, it's not recommended after the first one, but it is in LAM. And I think that's for a good reason. So the other thing that happens if you've had a pneumothorax is that there are problems in terms of diving and flying. And this presents a sort of problem if people are wanting to travel. And it represents a danger because you don't really want to be in the middle of nowhere and have a pneumothorax. It's not a safe thing to do. And the reason that there are restrictions on flying after a pneumothorax is because of the pressure changes that occur in the lung. So suppose you've had a pneumothorax and the little hole in the lung has healed itself. Well, if the healing is not very secure, if it's new and it hasn't had lots of scar tissue put all over it, then it's actually quite fragile. And when you go up and down in planes, the pressure changes will actually put this little repair area under stress, and sometimes you can get a recurrent pneumothorax. So for that reason, people with a recent pneumothorax are not allowed to travel by airplane. And that makes sense. And the airlines are usually quite strict about that, and that's sensible. And the reason they do that is to ensure people aren't having a problem on the plane. Because again, as I was saying, this is one of the things that happens on airplanes. The other thing that people can't do is dive. I mean, I'm not sure whether many of the tuberous sclerosis patients will be diving, but this is actually a problem for some people who come, often they'll come to Australia from a long way away and they'll really, really want to dive. And it's difficult for them because they're not allowed to. And it's the opposite of going up in the airplane. The pressure changes are the things. It's the change in pressure rather than the actual pressure that's the problem. So that's one of the reasons, again, that we try to ensure that everybody is checked out early so that this sort of thing is prevented rather than causing a problem. So the next thing I'm just going to cover is chylothorax, which is where one of the lymphatics in the lung, which is dilated, as you know, in LAM, as I told you in the earlier pictures, pops. Now, the lymph system is the sort of under-recognized system in the lung. It is a system, it's a sort of third circulatory system. And this consists mainly of chyle, which is a sort of milky fluid, but also it's a place where the immune defense cells can go through. So there are quite a few macrophages and lymphatic cells that live in the lymphatic system. And in lymphangiomyomatosis, the lymph channels are dilated and they can sometimes pop. And this time, instead of getting a pneumothorax, you actually get a pleural effusion. So pleural effusion just means fluid on the lung. And it builds up at the base of the lung in the same way that air builds up at the top of the lung with a pneumothorax, because it can't get anywhere. It hasn't got a way of getting out. The lung is an enclosed space. And on an X-ray, you can see it often in the corner of the lung. Okay, so if you look at the left, you can see what we call the costophrenic angle. So the angle between the diaphragm and the chest is nice and sharp. But here on this side, it's obscured. There's this white area here. So that's what we call an early pleural effusion. If you look at this one on the right, you can see that's a very large pleural effusion. So this person will have a lot of fluid in the lung and will be very, very breathless. And again, the treatment is pretty identical because we have limited things we can do with the chest. And so what you do is you actually look at it very carefully. And now we do it with an ultrasound machine. We can do that at the bedside, in the emergency department, or on the ward. And you look at the patient. So this is the patient's arm up there. This is the chest, and you can see the ultrasound machine being applied to it. And when you look at that, you can see where the fluid is. And therefore, it's safe to put a needle in and take a little bit of the fluid to look at. That's what they call a thoracentesis, or a pleural fluid aspiration. And then the next thing to do, if you can't get fluid out just enough by taking it out with a needle, the next thing to do is to put what we call in an underwater seal drain or a chest tube. And you put this into the pleural space down there, and basically you drain it out. And so people are left with this drain in the chest. And then what we do is we actually look at the fluid. Now, normally, pleural fluid, or the small amount of fluid that's there for lubrication, looks sort of yellowy. That's what it actually looks at. And a lot of you get fluid on the lung for a number of different reasons. The commonest ones are pneumonia and then heart failure. But it normally looks like this. It looks all sort of yellowish. Whereas when you have chyle, which is the lymphatic fluid that comes out of the lung, it looks milky. And interestingly, it also changes according to what people have eaten. So if they've had a fatty meal, it'll become milkier. So that's something that is very specialized, and the treatment of chylothorax is not something that, again, is pretty rare. So it's not something that a lot of people will have had much experience with. And again, that's best dealt with by someone who's actually treated a lot of people with chylothoraces. I'm not going to go into the details, but essentially, if you've got tuberous sclerosis complex, then usually if you're treated with mTOR inhibitors like everolimus or sirolimus, then that usually works very well. The other thing that we get in in tuberous sclerosis is this funny condition which is called multifocal micronodular pneumocyte hyperplasia. And on this CT scan, you can see here that these little dots, these tiny little dots here, okay, down there and a couple on the other side, okay, and that's what it looks like on a CT scan. And we don't know much about MMPH. We don't know why it happens. We don't know what we do know the type of cells that are involved. But we do know that it's totally benign. It doesn't cause you any problems. Nobody has these symptoms with it. We pick it up on the X-ray. And the main problem is that people sometimes think that it's something else. And they don't make the connection between tuberous sclerosis complex and MMPH. And I remember once hearing about a patient who was actually told they had a nasty cancer for this, and because of the CT appearances, and underwent biopsies, and in the end they realized it was a benign condition. But it's much better, again, if you realize what it is early and treat it the right way. And you can actually treat it very well. The treatment is the same thing with an mTOR inhibitor, and it doesn't usually cause any problems, which is just something to be aware of. And this is just a picture of a patient of mine who did very well with treatment. This is the before treatment CT scan, and this is the after treatment CT scan. And as you can see, it's almost completely resolved, and it didn't need anything to do about it. So when one's diagnosing lung disease, the sort of investigations that one does are the things that I've basically been talking about before, and which I'm sure you'll be covering in the rest of this conference. The CT scan of the chest is the main thing, and also very careful clinical examination to make sure that all the skin manifestations of TSC are properly appreciated. And then we can do lung function. Lung function is not easy for everybody, particularly for people who have disabilities, and therefore I'm pretty flexible about it. If I've got a good CT scan and I can use the lung emphysema software, then I'm not too fussed. It used to be used very much for predictive purposes in LAM and to see whether people were getting worse, but nowadays, we use it primarily because we haven't got on with doing better ways of monitoring progress. And we do a VEGF-D, or at least we try to do a VEGF-D, which I'll talk about in a minute. And then we haven't really, we don't really do biopsies anymore. We used to, but only if there's some problem with the differential diagnosis, or we haven't done any genetic testing, or it doesn't all fit together. And that's actually quite helpful if we have to, because the biopsy is the gold standard. So you will get a definite answer on that. But again, the way it's done is through the BATS biopsy, and like the pictures earlier of having that sort of technique done on the chest. And if you can avoid doing that, it's better to do that. So VEGF-D is something you probably, I don't know whether you've heard about it or not, but essentially it's a blood test which was developed by Frank McCormack's group in the Cincinnati, and it is used as a diagnostic test for LAM. And it has quite a good, what we call sensitivity. In other words, it picks up disease, and specificity. In other words, it's good, particularly for looking at LAM. So it's a useful thing to get access to if you can. We have problems with access to it in Australia because it's not subsidized by the PBS, and it's a very expensive assay to do if there's just one person. And we have to send it to specific laboratories, and it's not actually licensed for medical use here. So on the whole, we won't necessarily do this, but we'd like to if we possibly could. And that's one of the things we'd like to actually get up and going for patients. There are specific guidelines as to diagnosing LAM. We tend to follow these fairly carefully. There's definite probable and possible LAM. If someone has tuberous sclerosis complex or had a clinical diagnosis of tuberous sclerosis complex, then pretty much nothing else is needed. If you have lung cysts, then you will have LAM if you're in the context of tuberous sclerosis complex. But a lot of people, it gets a bit more complicated because sometimes we will see people who haven't yet been diagnosed with tuberous sclerosis complex and they present with LAM, and then we will try and diagnose with TSC afterwards. So how do we manage LAM? Well, we manage patients the same way we do with all other diseases, general advice and counseling. Obviously, it's crazy to smoke, and it's crazy to smoke anyway, but in LAM, it's even crazier. And I'm pleased to say that most of my patients have, hardly anybody smokes anymore. Vaping is very bad as well. And although we don't have data on that because it hasn't been around as long, it is actually very dangerous and should be avoided as much as possible. And particularly in children, if they're going to take it up, it's something which, I'm sure you agree, is not a good idea. And trying to maintain normal weight because obesity has effects on lung function. So basically, it's advice. And I'll talk a bit about pregnancy and contraception and warning about the risks of air travel, in particular pneumothorax. And we don't stop people from traveling by air nowadays unless they have really severe disease. And very occasionally we will recommend a prophylactic VATS pluridesis if someone's very, very keen to go off and go diving or traveling around South America or something like that, which is very hazardous. But on the whole, short-term air travel, if you don't have much in the way of lung function impairment, is pretty safe. Pregnancy is another issue. Contraception, there were recommendations originally that no estrogen containing contraceptives should be used. On the whole, the data with that have backed off a little bit. But on the whole, progesterone containing rather than estrogen containing contraceptions are probably preferable, or other methods, because high estrogen states definitely do make LAM worse. Again, it used to be suggested that pregnancy was contraindicated in LAM. And again, that has been revised to a certain extent, but still is one of those medical conditions that is where pregnancy is not recommended. And it's a very specialized area. And certainly in Sydney, we have a number of obstetricians who are particularly interested and helpful in this regard. It's one of those conditions where we would back women to have things like assisted embryo growth. And IVF also is a problem because you get very, very high levels of estrogen with that. So it is an area which needs to be given expert advice on. Regular vaccinations are key, and there's no reason for having none of the usual ones with tuberous sclerosis or with LAM. There's no contraindication to those. Again, the usual sorts of supports. Depression is quite common, and there are all these other issues with tuberous sclerosis complex. And then the other thing is, patients do better with multi-system referrals with a TSC or LAM clinic, and there is a network of such physicians in Sydney. Just to talk a little bit more about pregnancy in LAM. Pregnancy is no longer regarded as totally contraindicated, but it does give you accelerated disease progression and also a pneumothorax. And it's something which is not to be embarked upon without having specialist advice, because I have seen occasional women who've had really, really bad progression of their LAM. And, you have to think about the long-term situation for the child and for the family, as well as for the individual. And I have had a couple of patients who've actually had, prophylactic procedures in order to be able to proceed with pregnancies. And that, I think, is really good because it enables families to be made without the same degree of worry and certain amounts of reassurance. But I have to say, most women with LAM don't have terribly many children, but there are quite a few women who probably have had children without having any problems. And that's really well documented before the diagnosis was made. And I think this is an area we still need to do quite a lot of work on. The other thing is that there's a worry about the use of mTOR inhibitors in pregnancy, but you can use mTOR inhibitors. The data in terms of it being detrimental to the fetus there's not huge amounts of data. It does actually probably mean that there's a high rate of fetal loss. But on the other hand, it's a balancing act between, having a woman having her family and ending up with an incurable, prognosis and possibly a lung transplant as a result. So it's a really difficult area. And I as a woman with a child, I understand, and I try to sympathize and do as much as I can to get women through this, get families through this, actually. It's one of those few places, one of those few conditions where surrogacy is potentially indicated. And although surrogacy is difficult in Australia, I have again had a couple of patients who've had surrogacies, which have been really successful. Medical therapy of LAM on a day-to-day treatment basis, we sometimes use inhalers. They probably don't work terribly well, but we try them out. Oral high-dose progesterone is no longer recommended. We don't use this routinely. It probably doesn't work. And the same is true with all the other types of treatments of LAM, which you might find if you consult Dr. Google. And we did a study on doxycycline, and we didn't find that terribly effective. However, some patients do find it individually effective, and it's quite good in preventing chest infections. And again, it's very cheap and relatively non-toxic medication. So I will sometimes prescribe that, but not really for its effect on LAM, rather than its effects in the individual. And then the mTOR inhibitors, which I won't go on about because I'm sure that you're well aware of the beneficial effects of these. And then there are various other trial medications, which potentially could make a big difference. And you'll all know about the MILES trial. This was specifically looking at the lung effects back in 2012, 2011 now. And essentially, mTOR inhibition is highly effective. It doesn't stop the lung function decline, which is what you worry about in LAM, the cysts getting bigger, but it does reduce the rate at which this occurs. And it has actually had an effect on seeing patients with really severe disease, I'm very pleased to say. And we are seeing fewer people who are now leaving lung transplantation because the use of the mTOR inhibitors has made their lungs less bad, which is what we want. mTOR inhibition is also very helpful for abdominal lymphangiolyomas that can occur with LAM. In this lady in particular, she had a very large, you see this big blackish gray area here. This is a lymphangiolymoma in the abdomen. It's not an angiomyolipoma, it's a lymphangiolymoma. And so this is before treatment, and this is after, I think it's about 18 months worth of treatment. And you see it's completely disappeared. So it's very effective. The last type of treatment, and one that you don't really want, but is effective, is lung transplantation. As you know, there are limited centers in which this is available. But there is now a lung transplant center in almost every state, not in Tasmania, as far as I know. I think they go to Melbourne for that. And essentially, if you have to have a lung transplant, it does work just as well as with other conditions. There are rare reports of the LAM cells recurring in a transplanted lung, but that's pretty rare, and people are already on mTOR inhibition because they're actually part of the transplant rejection treatment. So it does save lives, it does work. I wouldn't, however, say that this is an easy thing to do. It's difficult in terms of the workup and make sure you don't have any comorbidities and all of those sort of things. And it's something we want to avoid if we possibly can. But it is, something which can be life-saving for those people who are really bad, but hopefully not too many people really bad in the tuberous sclerosis group. Just a very quick thing on COVID-19, because I know that that's something that is up there in terms of anxieties and is a real issue. Actually, at the moment, there's still quite a lot of COVID-19 in the community. Essentially, it's not a problem. Originally, we were worried about the effect of immunosuppressants like mTOR inhibitors on COVID-19, whether it would actually make more likely to develop severe COVID-19, but the data was very nicely collected in a multi-center study, and it doesn't appear to be a problem. So essentially, your vaccine response to COVID-19 is the same, doesn't appear to be changed by treatment with mTOR inhibitors. The outcome in people is almost identical to who don't have tuberous sclerosis complex or LAM. And although if you have a really bad LAM, there is a small increase in terms of the risk of death or hospitalization with COVID-19, it's essentially not much of a problem. So that's really good. And I'm a vaccine enthusiast. I'm as someone who worked on the front line during the COVID-19 pandemic and risked my life before there was a vaccine. I am so grateful for the fact that there's a vaccine there. And I think everybody should benefit from this wonderful free thing which has been offered by our government and our scientists. Just one last slide or two. I'm leaving St Vincent's Hospital and moving the LAM clinic to Macquarie University Hospital, where Alan Glanville is there. It's going to happen on a Wednesday. It's already on a Wednesday, actually, and they're accepting referrals. And we do have a standardized database. We have a standardized approach. We collaborate quite well with the International LAM unit in Cincinnati. And we would encourage people with tuberous sclerosis complex and with lymphangiomatosis and cystic lung disease to come and see what we can do to help. And we continue to have close collaboration with the transplant service and with thoracic surgeons. And Macquarie does actually also offer some novel methods of biopsies, which are not necessarily available elsewhere. So in conclusion, if you have lung disease in tuberous sclerosis complex, it's not the end of the world. And there are a lot of things that can be done. There's been huge developments in this area over the last 10 to 15 years. And early treatment is highly likely to actually improve your long-term prognosis. So I would like to recommend that everybody should have treatment if necessary and have the appropriate surveillance early on so that they can deal with things and avoid problems. This will also enable us to learn more about how we can prevent these things in the future. And the best way to do this is with an international focus, particularly in rare diseases. As you well know, this has been very helpful in the past, and I think will also help in the future. And there are potentials for other types of biomarkers, which hopefully will be easy to do and don't involve blood tests, because I'm very aware of the problems with blood tests, particularly in a TSC population. So thank you for your attention. I'd be very happy to answer any questions that you have. And I know I won't be there in person, but I can at least offer email questioning if this is of help. So enjoy the conference, and I hope that I've covered the area to enlighten a few things. Thanks.